Welcome to the Nurse Break and the Nurses Collective podcast. I'm your host, Jackson, a registered nurse, and I'm thrilled to have you here. Each episode, we speak with Aussie nurses exploring their incredible careers. So grab your favourite drink, get comfortable, and remember, if you're watching this live, feel free to drop your questions in the comments for our guest. Let's get started. Hi, Tanya. Thank you for joining me tonight. We got there in the end. Tanya Frost is a stroke clinical nurse consultant at Eastern Health, a stroke clinical co-lead at Safer Care Victoria, and the co-chair of the Australian Stroke Nurses Education Network. And she has been working in stroke services since 2010 and has redesigned stroke services, led national initiatives, and I'm excited to have you join me tonight to share insights into everything stroke. Tanya actually presented at my workplace like 4 weeks ago, and I was like, this is a really cool presentation, so I need to interview this lady. So here we are. If you guys are watching this live, I know because we've had a little technical issue at the start that people have probably said they were going to come watch, aren't getting notified. But please post in the chat when you do come across this, where you're watching from. That'd be really cool to see. And if you have any questions for Tanya or myself as we go along, please put them in the chat and we may ask them live to Tanya. So Tanya, thanks for joining me. And do you mind telling me a little bit about yourself and how we got to where you are today?
So thank you so much for having me, Jackson. I feel like a bit of an imposter because I feel like we all just do our job. I'm a stroke clinical nurse consultant, and I fell into stroke many, many years ago because I was actually working down at Latrobe Regional Hospital, and we had a medical consultant say we really need to up our ante in stroke service. You know, Nurse Frost, you've got half a brain. How about we set up a stroke unit? I went, okay, what is a stroke unit? And from there on, I've gone on a massive learning curve. So over the last 15 years, there have been significant changes in stroke. I'm a naturally inquisitive person, so I wanted to know more. I didn't like that I had a knowledge gap. And so my quest in life has been about making sure that that knowledge gap is reduced for myself. And then I figure if I didn't know, then there's a whole lot of people out there that didn't know. And so I taught myself. I have had amazing mentors and medical staff and nursing practitioners and nursing staff who have taught me so much over time. And my passion became systems processing. A bit of an order process kind of person. And so what I found out really early was that we really needed just a system in place to coordinate the care. And once you got that system right, you could do amazing things for patients, and patients could have amazing outcomes. So really, you know, in the last 20 years in stroke care, you've gone from putting your patient going, oh, I'm sorry, you've had a stroke, to look at all these treatment options we have. And that to me is just absolutely amazing. I think the hardest thing about being a stroke nurse is there's no set education criteria. So you become a critical care nurse, you work in the ED or in the ICU. To be a stroke nurse, you are often taught on the job, and you do courses along the way to get there. You know, there's transitional to care processes, there's very generic postgraduate courses that you can do. And the master's that I did was actually a master's in advanced practice. So not necessarily just stroke related. And I did it in advanced practice because our stroke patients have multiple comorbidities. And there were lots of things that I needed to know. You're dealing with people in the emergent situation, and it's different to any other situation. So that to me is people who are motivated to learn and go through that processing is what makes a stroke nurse in effect.
Yeah, and I feel like a stroke nurse could be an ED nurse, an ICU nurse. It could be a stroke dedicated neuro unit, rehab unit. Like everyone could be a stroke nurse in some sort of sense of the word. Where do you find? Why should people care? Why should nurses care about stroke?
Because you can do something. So stroke is the most disabling disease we have in this country. And so to be able to do something to reduce that disease burden, not only on the patient, but on their family, their community, all of their loved ones, really is a privilege. And I think that that's one of the things that we remember, to deal with patients in their darkest days where they think that things are never going to be the same, where their lives can change, to be able to coordinate that care and that processing, knowing you're getting the best possible outcome for your patient, I think is just huge and a privilege.
Okay. We're going to go into a presentation you've actually prepared for us. So I'll just pull it up on screen, and then please just tell me when you want me to change slides, and we'll go from there. And I'll go quickly to the slide 1 because I've just skipped through. And let me just quickly fix that. Awesome. Can you see the screen?
Yep, absolutely. Thank you so much, Jackson. So I wear a couple of hats. I think one of the things about wanting to change systems means that you want to be involved in everything. And so I work at Eastern Health as a clinical nurse. I'm a clinical co-lead at Safer Care Victoria doing the Enhancing Stroke project. Amongst an amazing project team. Shout out to Simone and to Mel and to Ben Clissold, who just as passionate as I am about stroke care. I'm one of the co-chairs of ASNEN, and I've been involved in ASNEN for the last 7 years. And I'm on the Australian Stroke Coalition Stroke Unit Certification Project and the National Targets Task Force. So I'm going to start by talking about Eastern Health. We're a bit of a unique situation in Eastern Health. We have 3 main sites and up to 10, I think it is, smaller sites, but we have 3 hospitals that have emergency departments. Box Hill Hospital has been renowned for their stroke care for many, many years. In the last 18 months, I've been setting up service out at Maroondah Hospital just to supplement the Box Hill care. And at Angus Hospital, we transfer patients to either Maroondah or Box Hill for their continuing care. So they don't treat stroke patients per se. However, stroke patients will present anywhere, and you've got to remember that stroke doesn't hurt. So patients might walk in to, any hospital. They don't always call an ambulance. So if someone's having a fairly minor stroke, they might just walk into a hospital, but it's really important that they get the same level of opportunity and care in order to process. We'll go on to the next slide. So where does it all come from? I think one of the things is that as a nation, we really have strategic plans, we have processes, things that we know work. And this is largely because of what the rest of the world has done as well. And we noticed that stroke care wasn't as processed as it could be. And I think the National Strategic Plan for Heart Disease and Stroke came out in September 2020. We're now sitting in 2025, and we're really actively doing some things about this National Strategic Action Plan. You can imagine the cost of a disabling disease to the community, to the health service, and to their own life. And so those with lived experience really deserve and need to know that we are working in a process that gets the best outcomes for them. Next slide, please. So part of that is stroke unit access. So the National Stroke Foundation did acute audits every 2 years. The last one was done in 2023, and they're not going to continue because the idea is that we're all doing continuous quality improvement. But we'll continue to get reports from them. But what we found is that we know that stroke unit care is a treatment. We have clinical care standards that tell us what we should be doing, and we know what the processes should be. And yet only 72% of our patients were getting access to a stroke unit. And that's really, we know that stroke unit saves lives. It reduces disability, and we know that people will have a better outcome after their stroke if they're treated in a stroke unit. So ultimately, we want that number to be as high as we can, and 72% means that almost, a quarter are not getting the care that they deserve. So along with that stroke unit processing is that hyperacute therapy. That is thrombolysis and clot retrieval. Sometimes it's just diagnosing and making sure that we've got the right processes in place. That's for an ischemic stroke. For a hemorrhage, then there's other things that are required, like maintaining blood pressure and providing homeostasis for the patient. What does all of that mean, and how do we order that process? We know as a nation in Australia that about 29% of our patients would get their thrombolysis within 60 minutes of arrival to the hospital, whereas in other developed countries, it's up to 68%, 61%. And we're lagging behind. And so, what was it that we were going to do as a nation in order to improve that? We know that patients need discharge care planning and processing. We know that they need incontinence management, and they need risk factor education. And you can see how low those numbers are on the screen. And so being able to provide appropriate care doesn't just mean hyperacute therapy, but it means discharge planning as well.
Is that
Next slide,
because
please.
Australia is so big? Is that just the size of our country that contributes to the door to needle
I
time being
think
so low?
part of that is resourcing as well. So if you think about Victoria, we're really lucky in Victoria because we're close together. You look at Queensland, they've got massed vacant land areas that they've got to get through. And in Northern Territory, do they have all the services they require? WA is, a quarter of the country. Look how big it is. How is that process working? How are you getting the patients to where they need to be treated appropriately? So then a part of that was the Australian and New Zealand Stroke Organisation, or ANZO, paired up with the Australian Stroke Coalition, the Stroke Foundation, OSCAR, and the Angels Initiative. Everyone got together. Ultimately the stroke world of clinicians is fairly small, and we were all working towards a common goal sort of separately. And so they all got together and they said, we need to provide targets. And this is where the initiative of the 30, 60, 90 national targets really was born by some clinicians who were just really proactive in what was required in order to get the best care for the patient. So if you go to the next slide, we'll show you what they are. So the 30, 60, 90 targets means a national endovascular clot retrieval door to puncture time of 30 minutes for patients who are transferred. Now, endovascular clot retrieval is only available at a comprehensive stroke service, and that is not every stroke service whatsoever. So in Victoria, there are 5 hospitals that do clot retrieval. In every state it is a different amount, but it is not for the amount that we have of primary stroke services. We need to get a national median thrombolysis door to needle time of under 60 minutes, and we were sitting, just go back where you were.
Sorry.
No, that's right. We were sitting much higher, up to 120 minutes there. So it's, and that was as small as 4 years ago. A national median door in, door out time, and these for the patients that need to go off for clot retrieval, of under 60 minutes for a metro hospital, because there is less barriers in place than what there is for a rural hospital, which is 90 minutes. A median endovascular clot retrieval door to puncture time, so from the time they arrive to the time that they start doing that procedure, of 90 minutes for patients who primarily present to the comprehensive stroke service, and certified stroke unit care for 90% of patients with a primary stroke diagnosis. And these national targets were put out to be met by the year 2030. So still 10 years after that initial national heart disease and stroke program sort of was really born. And you can see the QR code there for anyone that wants to actually look up the national targets and where it all came from. So I've kind of discussed it a little bit so far, but I think it's worth knowing what your stroke service is or what is available to you. So a comprehensive stroke centre, or a CSC, is a hospital that provides 24/7 endovascular thrombectomy, and it has neurological services. A primary stroke centre, which is what we have the majority of in Australia, is a hospital that provides 24/7 thrombolysis along with stroke unit care. A stroke-capable regional general hospital, which is quite the mouthful, but it's a hospital that is geographically distant from metropolitan centres. It provides the thrombolysis and stroke care approximating a stroke unit, but not necessarily with all the services. But often they will have routine transfer protocols in place for a primary stroke centre or a comprehensive stroke centre. Sometimes that's completely infeasible, and other times it can happen. And so they are sort of an abridged version. One of the most amazing things that has happened in the last years is telestroke thrombolysis centres, where you can call in to get access to a neurologist. Ideally, that's 24/7. It doesn't always have to provide stroke unit care, but the patient can actually get the thrombolysis or a treatment plan quickly, because we know the sooner we treat, the better it is. Because if there's blood not flowing in the brain somewhere, then the brain is dying, and we need to reverse that as quickly as we can, just like we do for a heart attack. So exactly the same premise. We want to do it as quickly as we can. And then there are general hospitals, and these hospitals don't provide thrombolysis or stroke unit care, but they definitely have transfer protocols in place. So that's sort of the definition of what a lot of hospitals are about. And then it is all about these processes depending on how high level you are. So for a primary stroke centre, a stroke capable regional general hospital, and a telestroke capable centre, you really need to have systematic coordinated ambulance bypass direct to a thrombolysis capable hospital, depending on what level you're at. The ambulance should be pre-notifying, so the stroke team are there at the door waiting for that stroke patient to start deciding on treatment decisions right from the minute they get there. There are so many stroke toolkits that are out there now in order to be able to coordinate this processing. The idea is that the patient is rapidly triaged and sent direct to the CT scanner. You either attach a timer or a clock, or everyone is watching time, just like you would if someone had airway problem, if someone had heart problem. This is a medical emergency, and you are watching the clock because you want to treat as quickly and as safely as you possibly can. There is a pre-consent in a lot of places, or an assent we use to treatment. So that's basically discussion only. They don't have to sign that they're going to have the treatment because it's an emergent decision. And we can't do anything until we know what's going on in the brain. And so we have to get to that CT scanner. And direct to CT is the single most effective thing as a hospital that you can coordinate. You need to take pathology for rapid assessment, because lots of things can mimic stroke. If people have metabolic derangement and those sorts of things, it can mimic stroke. And so not only do you need to use your patient assessment as well as your imaging criteria, but some pathology can help, especially if someone's on a DOAC or a direct oral anticoagulant. And we're still working through exactly what that safety process is, but knowing whether or not their levels are okay. There's lots of work going around that. We need rapid thrombolysis. So just because a patient presents to you within 60 minutes of their onset of stroke doesn't mean you have 4.5 hours to treat them. It means that you want to treat them as quickly to that onset as you possibly can. Imaging needs to be reviewed. Not every centre has someone that can actually look at the scan and read the scan. And sometimes there can be delays in getting a radiographer to be able to actually, a radiologist, sorry, to be able to read the scan and to be able to determine whether or not thrombolysis is safe. You can thrombolyse on the CT table, and then you have a team-based approach around every single parallel task that goes along with that. If you need to get your patient out to a comprehensive stroke centre, you have a door-in, door-out protocol, which means that you're quickly calling ambulance. You've treated the patient if they're eligible for thrombolysis, and then you're sending them back out the door for clot retrieval as soon as you can. And then we say prompt data feedback, because everyone in the team needs to know exactly what's going on. You need to know what your numbers are so that you can make improvement and see where your delays are. Comprehensive stroke services obviously have door to puncture time and those things in it, and enacting the thrombectomy team, which I just haven't put in that because it's just a slight difference. But part of this incentive process, the World Stroke Organization and the Angels Initiative got together and have created these WSO Angels Awards. And in effect, it's saying, where do you sit nationally in order to be able to get that processing correct so as that you can treat your patients faster and improve their outcomes. So this is all about reducing disability. This all has a person whose world is being rocked at the core. And I think that these awards are just absolutely fabulous, because what they really do is, number one, show where you sit as an institution, but two, show that you are actually improving outcomes for your patient. Show whether or not you're being effective in your treatment processing, and then making a difference to your patient. And go on to the next slide. So I've discussed that hyperacute phase, and that is really important. The reality is maybe 10 to 15% of Australians are actually eligible for thrombolysis and clot retrieval. However, every single stroke patient is eligible for stroke unit care, and it is a treatment. This slide is courtesy of Tim Kleinig, who is the head of the ASO at the moment, ANZO. And really, it just shows the benefit of what stroke unit care can provide. So to have coordinated processing, to have a coordinated stroke unit, the number needed to treat is 50 to prevent a death in stroke. However, the number needed to treat to reduce death, dependency, or institutionalization is 17. Now, that is really low in a lot of things we do in a medical world. And so we know the faster we do that, the faster we get our patient treatments decisions made, and then to a stroke unit, the better off that patient will be in the long run. What we know works to be able to say we really need to get this in our institution is to prove that it is effective, that it reduces length of stay and reduces cost burden. Because although we are talking about care for people, we know that that care is not limitless. And so if you're treated in a stroke unit after your stroke, you have on average a length of stay reduction of 4 and a bit days. You also save $3,000 a day, or about $13,000 per patient. So not only can you improve the patient's outcome, but you are assisting in the processing that we're all in. All right, it's the reality of what we are, is that we're in an institution, and we don't have limited resource. So that QR code on the page too is just a link to the papers that are there.
Yeah.
So stroke unit care. So structure and organisation. How many presenters do you have? Therefore, how many bed numbers do you need? What is the staffing around that? What skills, training, and communication do you need to coordinate that care? Now, already I've spoken of ambulance, emergency departments, imaging departments, and a stroke unit. That's 4 departments that a stroke patient will go through relatively quickly. And we need to make sure that that is systematic, process driven, and for the best outcome for the patient. A stroke unit should monitor the quality of the care they're giving. So, and that's part of what OSCA, which is the Australian Stroke Clinical Registry, we input data into that, and they determine where we're at. And this is the genesis of the WSO and Angels Awards as well. We need to make sure that our processes of care enable acute assessment and intervention, early management, and patient management and discharge planning. And when I say patient management, I mean good nursing care, good allied health intervention where it's required, and that discharge planning and follow up. So that, that is a big thing. People are not in hospital for a long period of time anymore. And how are they coping in the community? What level of impact does their stroke have? And what does it not only have on the patient, but also their carers? So key points: stroke units improve outcomes after stroke. The process of care has been poorly understood until now. we describe a complex multidisciplinary process when we talk about this, where we're going from a lot of departments within a hospital and a lot of staff, and especially our allied health staff, who can start that early rehabilitation to start that improvement process happening. And really, we should have benchmarks. We should be involved in whatever research we can do in order to determine exactly what's happening within our own institution. Now, research isn't necessarily being part of a massive worldwide clinical trial. Research is what's happening in our own backyard sometimes.
For the about 116 people so far come through over the last 27 minutes. Excuse the first 2-minute error. Those who are watching, please chuck a little comment wherever you are watching, YouTube or Facebook or the website, and just let us know where you're watching from or if you have any questions. Yeah.
I think one of the biggest things is that people think that to have a stroke team, you need a massive amount of people. And one thing that we did was we did a body cam research activity. It was really more a quality insurance activity, just to say, how many people do you actually need at a code? Is it the specialist people? What is it that really makes the difference? And you can see here where we look at the team size at the code, is that actually most of the time there are only 2 members. So 3/4 of the time there are only 2 members of the stroke team actually available. And what you can actually achieve, Eastern Health has really proven over time, with 2 people, and that is a medical professional and a nurse who have a sole focus on ensuring that patient gets the right amount of care. So we recorded 100 stroke codes. We figured out what was happening in hours and what was happening after hours. And of course, I don't work in the middle of the night. We're relying on ED staff. And so that nurse can actually be anyone who is set to a high acuity area, or even, in fact, someone in a low acuity area. If your patient gets symptoms, you just need to go along with ride with a medical professional who can escalate that care as well. And it's that teamwork that I think we forget. And the beautiful thing I think about doctors and nurses working so closely together is that we come from slightly different perspectives, and so the care is really rounded when you're dealing with the patient. You can go to the next slide.
It's interesting that you've got a research nurse. Is that at Eastern Health? Attended 18-ish%?
Yep. So the thing is that we have at Eastern Health, we have high amount of clinical trials that we put our patients into, because we're a university hospital in effect, and so the research nurses are there to determine whether or not a patient qualifies for any of the trials that we have going on.
Yep.
Just really basics at Eastern Health. What's worked for us? Knowing our resources. All right. Resources are not limitless. We may only have 1 or 2 people who are available in order to do things, but you can make absolutely big bounds in what you're doing. Some of those resources are internal and some of those resources are external. So where can you get your information from? What professional governing bodies can you be a part of? And this is where I'm so passionate about ASNEN and educating people to know these things. Every single reperfusion case we have, we dissect into times, what the delays are. We have a weekly meeting where we discuss this, and we can enact and react very, very quickly to something that we see that is occurring. So you notice themes when you start looking at every single case. You notice what is working really well, and you can find out if something didn't work really well for a patient, why that was the case, and prevent it from happening again. And so you can enact the whole time, and the process flows. Feedback to your teams. Now, I say bribery works because I'm known for giving chocolates if you get good door to needle times, good door in, door out times. I call them ICU chocolates, because at 2 o'clock
I
in the
need one.
morning, when we have a stroke champion in ED, who is the person who is pushing that bed and getting the patient to the CT scanner while our doctor's on the way in and ordering that process, absolutely
Mm,
deserves just as much credit as anyone else. The person
mm,
who printed the labels and pre-put the patient on the system so as that that process could even begin, because you can't do anything without a label, right? Patient needs to be registered. So every
yeah.
single person in that process is just as important as the person reading the scan and pushing in the drug. And I think that
Mm,
that has really been our biggest success, is seeing everyone within that team. And then it's real obvious, but talk to your team. Talk to your stroke team about what works well. Debrief your doctors when they've had a middle of the night code that has gone terribly. Celebrate them when they've had one that's gone really well. Your ED team, your CT team, your ambulance crews, and your stroke champions, wherever they may be. That's in the hyperacute phase. And then stroke champions are also on the ward. So when you know that they've had a particularly rough shift and they've done something great in that shift, or they've just worked really hard, letting them know that
mm.
you see them, I think, really makes a difference. And literally, save a minute, save a day, right? I love a slogan. But we know that the onset to treatment time, the quicker we are, can save 1.8 days of extra healthy life.
Very significant.
All this benefit,
Mm,
absolutely, all this benefit is seen across every group. So it doesn't matter how severe your stroke is, it doesn't mean if you're old, it doesn't matter if you're young, and every single person actually benefits from us coordinating that care and initiating treatment, whatever that may be.
How
Women gain
how
slightly more than men. Mm.
how common is stroke in young patients?
So a quarter of our stroke patients would be under the age of 65, but probably under the age of 50. So you're
So
talking about people who are working.
right, yeah. So what's the definition of young, I guess, in the stroke cohort?
Yeah, so really probably under 50 is young.
Mm,
But as I'm approaching that, I think most of us really think under the age of 65. And when you look at how we're working longer now than what we ever have before, we don't
mm,
retire at 55 or 60 anymore. The impact is actually quite high. So it's really not about necessarily what age you are, but how comorbid you are. So you can
mm,
have someone who is 60, has no comorbidities, has a stroke, and that has massive impact. You can make massive improvement in their processes and their care.
mm,
Someone who is 55 and very comorbid has a whole lot of other disease processes happening. The impact can be
mm.
less. And so it's
Yeah,
all
right.
about how well you were pre-morbidly. Does that make sense?
Yeah, yeah. It's very significant. 3.5 days is just wild.
In a young severe stroke patient. Yep. Yep.
Mm, mm. I
Yeah.
guess
So
those who are watching this or listening to this in the future, welcome. But if you want to watch these slides, just pop onto the video version on the socials, because there's some really good graphs on these slides.
yeah. I think the big thing to take out for someone who's having a very big stroke, a large vessel occlusion, we call them, every
Mm,
15-minute decrease in treatment delay provides 1 month of additional disability free life for the patient.
mm,
So that is huge. So
mm.
every minute, save a day, literally.
It rhymes with
So
Eastern
the
Health
Eastern
Way.
Health Way, and I think, yeah, one of the beautiful things about Eastern Health is that we've had data for such a long time, right? And when you have data for a really long time, you actually see what things have made a difference. and often starting, and I've got a full-time ASN because we were originally known as acute stroke nurses. So, the language around that has changed a little bit, but having someone, and we're a high volume center, so full-time is appropriate, right? But having someone who is there 6 days a week has made a massive, massive difference. The direct to CT protocol, again, significant improvement. And what we saw with that direct to CT protocol is that in the after hours space, it may have taken us a year to really get it into the after hours space, but it made a significant difference. So the grey line up the top is onset to needle. Often we can't control when our patient comes in. The orange line is door to needle, and you can see that drop once we started really getting our after hours direct to CT protocol going. And then the yellow line that only starts part way is really because in 2015, clot retrieval really became a big thing, and we really started then monitoring our door in, door out times. So that's why there's a bit of a lag there. And then door to CT, and you can just see how that door to CT has really made a difference with the reduction of our door to needle time and the reduction of our door in, door out time. The thing that I love most about this is that COVID made no difference to our door in, door out time because our processes were in place. So you had a national pandemic going on, you had staffing doing all sorts of weird hours and positions. I was even taken out of my position for a while. But the processes were there, and because the processes were already set up and in place, they continued because we could see the benefit that was required for our patients. And since the national targets have come in, Eastern Health really are aware of the role that they have in continuing to improve that our door to needle time, our door in, door out time, because we have resources, we have processes that are in place. Therefore, we have a greater responsibility to make it lower to help reduce that national target. We're already well under 60 minutes. Okay, we're already there. We're well under all the national targets already, but we can be faster. And so we're pretending that we're not. As I said, the single most effective thing you can do is direct to CT protocol. The assessment starts at triage. So as the triage nurse is writing acute stroke onset time in the triage, we are starting to assess. As soon as you go to an ED cubicle, you really lose 15 minutes. And that's because you've got to take their clothes off. You want to put them in a gown. You need to connect them to the monitor. Someone might take blood there. None of that stuff makes any difference because they're already monitored on AV. The IV is in, hopefully, from the AV, and we can keep that bed moving. One of my biggest tricks is just to start pulling a trolley because everyone runs after a moving bed, yeah? So if you just get that bed moving, then the patient is going in the right direction. You can assess as you walk. We can determine whether or not they've got an IV and where we need to put it in. While the CT is being set up, we can put the patient, we can take bloods. If they're a really difficult cannulation, we can get an ultrasound that is required in the CT. While that CT is being set up, we can get that IV put in and bloods drawn at that point. Making sure that the appropriate staff know. So a call in to CT. Who gets notified when that code stroke happens? For us, it is ED, the stroke team, CT, the hospital after hours coordinator, because they're going to know that we might need a bed or that the stroke team are really busy and maybe we need to start looking at other processes. And then how many from that stroke team are actually required. And remember that I said you don't need a cast of thousands, although sometimes we have quite a few people. However, you really just need 2 dedicated people who are not pulled off to do other things. So, I don't know what happened to my slide there. My apologies for the thrombolysis. But really, there's 2 treatments. Yeah. There's 2 treatments for stroke. There is tenecteplase, which is just a push, or there's alteplase, which is actually a push because it's a trophic drug, and then you have to run an infusion over an hour. TGA approval is on its way in, and TNK is becoming much more prevalent and is much easier to use than what alteplase is. But every site is different and what they're doing. You just have to know what your site's doing.
Okay.
Now, it is approved for up to 4.5 hours from symptom onset. But we know with advanced scanning that up to 9 hours, sometimes even up to 24 hours in selected patients, actually can provide a benefit. So onset time to delivering the drug was at the start, when thrombolysis first came in, was at 3 hours. It expanded to 4.5 hours, and now we're doing it well outside those time windows on selected patients, because we don't want to cause harm, remember, and on it's all related to the scans and perfusion imaging often. We know the quicker we get it in earlier from onset, the better the outcome will be for the patient and the less side effects there might be. And it's one of the side effects of lysis is bleeding, and that it can be catastrophic. And so we want to make sure that we're selecting patients that are appropriate. Not everyone is eligible. If you're having a very mild stroke, we did a trial with TASTE, which was seeing if we give people with mild symptoms dual antiplatelets, so that's aspirin and clopidogrel, or we give them thrombolysis, and there is no difference between the two. And so we know that giving dual antiplatelets is causes less harm. And so therefore, we know for people with very mild strokes who don't have a big perfusion deficit, actually do better with giving them dual antiplatelets even when they're in time. And so because of all these trials, clinically what we do, it changes. Next slide.
I remember in the Northern Territory sending a patient 8 hours after presenting due to the delay to get to the hospital, and then fly to South Australia.
Correct, because Northern Territory doesn't have any comprehensive stroke services. So South Australia takes on through that whole centre.
Yeah.
And then when we're talking thrombolysis, and I'm saying, the faster the better, the quicker the better, that's great. If you can actually treat a patient within 90 minutes of their symptoms starting, 4 to 5 of them, 1 in 4 sort of get up and walk out of the hospital, in effect. If you're in that 90-minute to 3 hours, you need to treat 9 patients in order to get that same effect. Up to 4.5 hours, it's 14 patients to have that same effect. So when I have my stroke, I want to be in that 90-minute bracket. I want people to have systems and processes in place so as that I'm treated much earlier and brain death will be less. And if you're talking outside that 9 to 24 hours, it can be up to, number needed to treat of 25, which is why you need to be very selective of your patients. And now we're talking clot retrieval. So endovascular clot retrieval, EVT, so endovascular thrombectomy. The terms have slightly changed over time, but these are for the very big strokes, those that have what we call a large vessel occlusion. So that is an occlusion in the middle cerebral artery, which is the big ones that come off the carotids into the brain. And we call it M1, which is the first section, or M2, which is the second section, or a basilar artery. Now, you've got a bit more time with clot retrieval, so it is up to 6 hours, but bearing in mind, comprehensive stroke centres are not everywhere. There are less of them. And so the chances of you self-presenting to a primary stroke centre and needing transfer out is higher. Therefore, we need to have those processes correct. This is the physical removal of a clot. They either go in through the wrist like they do for a cardiac angiogram, or through the groin, but they go through the heart into the brain and physically remove the clot. Can only be for those large proximal clots, and so by proximal I mean closest to the circle of Willis. And groin puncture should be at about 6 hours from symptom onset. However, we know that up to 24 hours, that actually can be really effective. These are the strokes where 1.9 million neurons a minute die. So every minute you delay, there's harm being caused to the patient. So how do we do this process, right? Many, many years ago, they came up with the golden hour. So this is what needs to happen in order for when a stroke patient comes in. So the a suspected stroke patient arrives. Within 10 minutes, they get a doctor evaluation. So that means they're triaged as a category 2 for those that are ED nurses. The stroke team gets notified. They get to the CT scan. Then they decide what's happening on that CT scan. They look at the labs. They go, okay, we should treat this patient. That's an hour. If you go to my next slide, you'll see how we can massively reduce this hour. So if we pre-notify and we get the stroke team at the door when the suspected stroke patient arrives, you've saved 15 minutes right there. If the patient goes direct to the CT scanner, from that fast triage processing, that early assessment to determine whether or not we actually, number one, think this is stroke and whether or not the patient's eligible, off we go to the CT scanner. If you have people that can read that scan, so either someone on site or the VST processing, then you can get your door to needle time to about 30 minutes. At Eastern Health, I think our fastest is sitting at 14, 15 minutes from door to needle time. And that is because someone was very obviously having a stroke. Everything was in place and they didn't have any contraindications. All right. So it was you can do it that fast. The majority, though, of our patients are about that 30-minute mark. And that is really because of the processes that are in place. So having your stroke team know that a stroke patient's on the way in, having them at the door ready to prepare, labels are ready, triage is occurring simultaneously. The patient's going direct to the scanner. They've already got an IV in from ambulance, and then you're reading the CT and determining the treatment course. So it can be much faster. So then we look at the ideal door to needle and what is required. So there are some things in a hospital and in a system that just take time. So there was a collaborative work by Felix in regards to exactly what was required in a door to needle time. You need to get to a scanner, right? So it takes a minute to transport the patient to the scanner. It takes 13 minutes to do the full protocol of imaging, right? So this is time that you sometimes cannot reduce. And then concurrently getting consent, speaking to family members while they're having their CT scan, preparing the drug and administering that drug. And that is, in effect, your hour, if that makes sense. So breaking down that processing and knowing what works, I think, is really helpful. Again, so Peter Park, Dr. Park, who was our fellow at the time, is now a neurologist consultant, did an amazing work of all the data and just to figure out exactly what it is that made a difference in what years. So 2003 was when AV pre-notification started. We had workflow modifications that occurred all the way through that. Having availability of CT, okay, having the dedicated stroke team, having direct to CT protocols, all of that is workflow processing that you need to do in the background so as that you know that your patient can be taken direct to CT. Then what does that core staffing team look like? Having your stroke coordinators, your acute stroke nurses, your stroke CNCs, your stroke NPs, whatever you want to call them, having them available during hours can create that flow and effect as the rest of the team, which is the ED team, learn that stepwise processing. And then clinician behaviour change. And a lot of it is about our thought processing when it comes to stroke. It is a medical emergency. We need to be able to make sure that we are reviewing all those cases, looking at what works well and trying to enact that every single time a patient comes into the hospital. You can go on to the next slide. So none of it works if you don't have champions, right? You also need tools to empower those after after hours. So I'm acutely aware that when I am the stroke nurse, my only concern is the sickest patient in front of me, right? I don't have a patient load per se. And so, how do we enable clinicians who stroke might be 5% of their workload? How do we make life easier for them? We developed a triage flow chart. And as I said to you before, we've got 3 hospitals, so they're all different. So Angus has one, Maroondah has one, and Box Hill has one. And this flow chart talks about that premorbid level of function, right? If someone has a very good premorbid level of function, then they're less likely to have contraindications to thrombolysis. If someone doesn't have a good premorbid level of function, then we need to know and make sure that they're okay to treat. Then what was their onset time? Their onset time then determines sort of what path you went. I think the biggest thing about all this is when all else fails, call us, right? Contact the stroke team. Stroke teams are very used to being woken up in the middle of the night. Stroke teams are very used to having calls after hours. A lot of our patients present after hours, right? And so, how can I enable the triage nurse to say, this is what I should be doing, and this is the process and the flow that really I should be going for each of my patients? So, empower your champions. I've discussed imaging. I've discussed going to CT. What is the purpose of the CT? As much as I really try, no matter how many years I've been a stroke nurse, I cannot figure out what's going on in the head until I see it. So we need a non-contrast CT scan, and that just determines what the brain tissue looks like. We need a CT angiogram, which tells us what the vessels look like. We need a perfusion scan for hyperacute stroke patients. And that perfusion scan tells us how long it takes for blood to get from the heart or the apex all the way up to the top, of their head. And if there's any areas where the blood's not flowing, then it's blocked. Okay, so what is that about? Now, this is for ischemic strokes. If you've got someone who's had a hemorrhage, they will often stop at the CT non-con and the CT angiogram, because the angiogram will tell them what their vessels are doing as to maybe why they've had their bleed. Right. If they haven't got blood on there, then you're going on to a perfusion scan. Sometimes patients, you do the non-contrast CT scan, they may be in early stages of renal failure or something, and you decide not to do an angiogram. So the non-contrast CT scan tells you that there's already something going on, and therefore they wouldn't be eligible for reperfusion therapy. But if they've got a blockage, or they've had an ischemic stroke, or in their anterior circulation, then you want to do a carotid Doppler, because our carotids often are the cause of why we've had our stroke. MRI, it is not an unlimited resource. In Australia, there is no use for MRI in the hyperacute phase. We just don't have enough of them to get someone direct to MRI. There's also a whole lot of contraindications to MRI that you might not be able to ask your patient if they can't talk. And so we don't use it for everyone, and nor should it be used for everyone if you can see the stroke on CT imaging. So if you already know that the stroke is there, then you don't need it. I discussed thrombolysis before, and now we're going to go on to antiplatelet loading. So that's 300 milligrams of aspirin, 300 milligrams of clopidogrel. Sometimes people use tricagular or something else, but basically it's a loading dose. So is that, again, trophic drugs, your levels go up, and then you maintain a daily dose. We know through the POINT trial that 21 days is the golden time frame for the dual antiplatelets before the risk of bleeding outweighs the benefit that you give within that time frame. And this is where trials are so important to all the things that we do. So blood pressure management, and this is varies depending on the type of stroke. So an acute ischemic stroke depends on whether or not they were thrombolyzed. So if they were thrombolyzed, we really want that blood pressure under 185 on 105, because it reduces that hemorrhage risk for that first 24 hours. We know for an acute ischemic stroke, excessive blood pressure reduction actually can be harmful. And so we will tolerate a blood pressure up to 220 on 120 for a non-thrombolyzed stroke patient. So we call it permissive hypertension. And we only want to lower it by 20% within 24 hours. So if you've got someone who comes in with a blood pressure of 220, it's really only sitting at 200 the next day. Does that make sense? Now, what does that do for nurses? There's a whole lot of METCOR criteria that actually needs to be modified. We need to know what's going on in that patient's carotid so as that whether or not they need higher blood pressure or not. So there's lots of internal mechanisms that occur after you've had a stroke as well. If you go on to the next slide, we'll discuss someone who's had a hemorrhage. But the drugs of choice usually are labetalol or hydralazine. Some places use nicardipine. At Eastern Health, we just use labetalol or hydralazine. We give it IV to reduce blood pressure where we have to for someone that we're going to thrombolyze. Now, that can only be given in a critical care area or in the acute stroke unit. And if IV meds are required, it's always a good idea to make sure that you're doing it under sort of medical supervision. But one of the things that you can do is also consider giving oral meds as well, because you want to supplement, right? You don't want to drop someone's blood pressure, have it rebound up, drop their blood pressure, have it rebound up. So what else are we doing? One of the biggest things I'm going to say is avoid topical GTN, right? A lot of the times our patients actually can't eat and drink because they've got a facial droop and they're waiting to be seen by speech pathologists. But GTN is unpredictable. It vasodilates, which is not always the right thing to do in an ischemic stroke. You can also get a delayed hypotension, which is not good for the patient. Fever, sugar, swallow, maintaining homeostasis is really important. And I think stroke patients are the only cohort that you would treat a temperature of 37.5 with paracetamol within the hour. Treat a blood sugar that's greater than 10 and make sure they have an assist or a speech review. Now, we're wanting to maintain homeostasis. We know that if we initiate the fever, sugar, swallow protocol, then it has a 16% improvement in, processing and outcome for the patient. Glucose is toxic to brain tissue. Fever alters homeostasis. And so we want to make sure these things are happening and we want to prevent any sort of aspiration within that process. We then want to know why the patient has had their stroke, because it enables our treatment decisions. So have they had their stroke because they've got a large artery atherosclerosis within their carotid? And that is 15 to 40% of stroke, cause of stroke. Do they have a small vessel disease because of hypertension or they're diabetic? Do we not know why they've had their stroke? Do we need to keep looking? Was it cardioembolic? So did they have AF or other cardiac causes like a hole in the heart or something like that? And then there's other causes because of dissection, or they're hypercoagulable because of a cancer or something like that. There's lots of other reasons that you can also have stroke. All right, so that was a lot of information, but really, what's the take home? So what has it got to do when we're talking stroke? What do we really want to do? We want to go direct to CT, right? We can't do anything until we know what's going on in the head. If you want to reduce your door to needle times, the single most effective thing you can do is get a direct to CT protocol. You want to involve all the teams that are required. That way you work together towards a common goal. When everyone knows that what they're trying to do is for the best outcome from the patient, you would be surprised what you can achieve. I would love to say that just the people on the floor can initiate this change, but none of that change really occurs unless it's system-wide, and that means getting your bosses involved. So all your department heads need to be online, your CEOs need to be online with exactly what the processes are, what you're achieving, and know your numbers. Tell them, this is what we've achieved, this is what we've done. Celebrate your successes. Know your facts, know your numbers. They will tell you the impact of what you're doing. Monitor what happens in hours compared to out of hours and try and reduce the disparity. As I said, talk to your team. Be personable. Let everyone know what you're about. Get your ED and your ward stroke champions, because they're then there 24/7. Someone's around 24/7, and know your processes of care, because stroke is a medical emergency.
Okay, awesome. I think that's the last slide.
Yeah, I think so.
Awesome. I'll take that off. Anyone who is watching, there's a couple people watching currently. Please feel free to post a question you've got in the comments. Well, I've got a few other things we're going to cover. I guess I just want to backtrack for a second. What is ASNN?
So ASNN is Acute Stroke Nurses Education Network, and we are about educating the nurses across Australia. So it is a national initiative. We have representatives on the board of every state, and being able to try and educate the nurses in regards to process of care, and being the peak nursing body for stroke care in Australia. So we have lots of things in place. So we've got education modules. It does cost $67, I think, to become a member. And what you get is you get education modules for free. You get resources to every webinar we've ever done. You can phone a friend and say, I need help with this. Do you know someone that can help that? And so the idea is that we're almost like a community of practice as well.
Yeah, okay. A few more questions that we wanted to cover. Terminology. So could you explain things like hemiparesis, dysarthria, dysphagia, some of those words that nurses and other clinicians can add to their vocabulary? And then
Yes. So I love the term unilateral hemiparesis. And people go, huh? It means weakness down one side, right? So this is the thing. And I think people get stuck on terms, but so long as you can describe what your patient is having, I think that's the best thing. I love the term strokeosaurus. And that is was termed by the Stroke Foundation. And there's a whole lot of terms that they have on there just to try and debunk a lot of the myths about what it all means. But often in stroke, you have weakness down one side or numbness down one side. When you're talking the difference between dysarthria and dysphagia, you're talking about motor speech for dysarthria. So are they slurring their words? Are they having problems articulating, as opposed to are they having trouble swallowing, which is dysphagia? And so I have little things in my mind because, it takes me a minute to learn things sometimes. So I say dysarthria, it's about the speech, and dysphagia, it's about the swallow. So you have little things like that. And I think that once you make a reason behind a term, it becomes much easier to use.
Yeah, awesome. That's great advice. Another question that I'd like to cover was, what are some of the biggest misconceptions that clinicians generally, I guess, have about stroke care, things you think we need to know more about that you haven't covered?
Really, that it's not a medical emergency, right? It is a medical emergency, and we I've proven that throughout this presentation, but also that it is a medical emergency that requires systematic processing. It's a medical emergency that requires assessment, and so we have these assessment tools. Most nurses know the GCS, right? The GCS does not help you with a stroke patient. If your patient can't talk, their GCS is automatically 8 or 9. If your normal everyday patient has a GCS of 8 or 9, you're thinking about intubating, right? Not in the stroke cohort. It's different. We like to maintain homeostasis. We're treating temperatures of 37.5, blood sugars of greater than 10. It is very specialized treatment, and that knowledge is out there. It's just, where really do you find it? And you can make a difference as a clinician through really good nursing care for your stroke patient.
It wasn't a question actually I planned, but do you know much about the undergraduate level of education about stroke? Like, how much is embedded in curriculum?
Not huge amount. They tell you about what stroke is. You get told about fever, sugar, swallow, but it is a very small part of that undergraduate education. Much more, we are being reached out for ASNN to start talking at undergraduate, having seminars and doing those sorts of things, because
Yeah.
although the curriculum is there, don't get me wrong, the curriculum is there, but what does it actually mean when you're talking about a tiny cohort of every other disease process
Yeah. Okay.
that is in there? So I think that although there's an awareness, knowledge translation is where we've got a gap.
Yeah. Okay. I only have 2 to 3 more questions. But the second one of them was like, how can clinicians, nurses, I guess nurses, us as a cohort, get more involved? And I'm thinking definitely those from a regional, a rural, a remote, somewhere that there isn't these protocols in place, somewhere where the ambulance and the hospital don't talk.
Yep.
Where do people start?
Yeah, I think the stroke coordinator makes a big difference. And if you don't
Mm.
have a stroke coordinator, become a stroke champion for your patients and reach out to your local units, right? So for your ambulance units, reach out to them. What is it that works? And this is the beautiful thing about the project, the Enhancing Stroke project that we've got with Safer Care Victoria, is that it is enabling that coordination of care. And I think we need to translate that nationally, right?
Yeah.
So, what is it that actually makes a difference? Someone who is interested, someone who is passionate, and someone who starts looking at the systems and the process. You don't
Mm.
need necessarily to have a whole lot of education, and find a mentor. You know, I've unofficially mentored a lot of regional nurses out there, because I started in regional. All my family will have their stroke in a regional setting,
Mm.
and so they need to be great, right? So find someone who's willing to give you some advice and do those sorts of things. Reach out to ASNEN. There are a lot of resources out there. It's just knowing where, I suppose.
Yeah. Um, Now we touched on it a little bit. I just want to delve back into it. How does stroke, and definitely for those who are listening, they couldn't see the graph, differ from countries overseas? Like there are certain countries doing so well, but where are we specifically failing in
Yeah.
comparison to what their processes are?
Yeah, it is our hyperacute treatment and then our stroke unit care. And I think that we have come so far. Do not get me wrong. We have come
Mm.
so far, especially in the last 5 years. The last 2 years specifically, we have done amazing work as a nation, but we can still do better, right? So, we're not perfect yet. So, getting our thrombolysis rates up for our ischemic strokes. I think hemorrhages is somewhere where we're failing our patients somewhat. And so, we really need to make sure that our processes of care for hemorrhage are in place, and that our patients are getting access to the stroke unit, meaning they're getting allied health assessments, stroke clinicians who are either on site or not on site to coordinate
Mm.
their care and their discharge planning. And I think that once we get those things right, then you will see that our numbers get better. Once our numbers get better, that means we're improving patient outcomes. So we get very focused on numbers and what our times are, but we're improving life as a result of that.
Yeah. Now, just another question I had was about courses for nurses. So, what courses exist? I know you did advanced practice. Like, what
Yep.
is out there? What exists?
Yeah. So, Stroke Foundation actually have some online courses that you can do that are completely free. The Angels Initiative have the Angels website, and they have courses, but we have Australianized them through ASNEN.
Mm.
And so there is a membership fee to access them, but they are modules that will go right through um, what a stroke is, what tests a stroke patient should have, where they should be treated, what outcomes can you expect, what things should you
Yeah.
initiate, and it gives you the entire door, like onset to rehab processing of knowledge that you can accumulate the whole way through. So it does cost $67 to become a member, but you have free access to that. We also have webinars. If you are looking for post graduate studies. In Melbourne, I know that we have a postgraduate neuroscience course, but it's neuroscience. It's not necessarily stroke specific, but stroke is definitely a part of that. And there's one of those in every state. And then there is overseas the ANVC, so the Association of Neurovascular Nurses. You can do stroke courses through those. So I probably should send you some links to add to this so people can access those things. Not everything's free though.
Awesome. Yeah, no, 100%. And like, this is my final question for you, and it's been a great evening. Thanks for spending 1 hour and 11 minutes, but maybe we'll subtract 2.5 for a little glitch at the start. So thanks for there's a couple of people who've actually managed to stay on throughout, but we've had over 100 people, quite a few people who've actually come and watched little bits of it, and hopefully we'll have lots more share and watch this in the future. Where is stroke care heading? And I guess what's the next big thing for nursing or stroke in Australia?
Yeah, I think it's standardising care. So from regional to metro, giving support to our regional, our outback areas, and ensuring that it doesn't matter where you have your stroke, that you can still get really good, competent care. From an Australian level, sort of that's what we're at, and that's what those targets are basically asking. But know what your patient cohort is. So if you're in outback Northern Territory, you would have higher incidence of stroke, heart disease, diabetes, which are all risk factors. Yep. Knowing your environment and exactly what it is. And I think we've got a much greater awareness of that. If you're in a rural area, you're at a 17% higher risk of having a stroke because of where you live, and not necessarily having all the services that are available. So how are we standardizing that care? And then it is about, what are we doing? Clot retrieval is 10 years down the track. That's made massive impact. We know that how we treat mild stroke patients now. We know that they need access to a stroke unit, but what are we doing in that discharge planning space? Are we taking really good care of our stroke patients? So doing mouth care, sitting our patients out of bed, making sure they can figure out where they are in time and space, stopping them from getting aspiration, educating them, their loved ones, and telling them that rehab is a possible process. I think that that's really where we're heading. Oh, and then you've got mobile CT scanners, right? So we've got the mobile stroke unit in Melbourne, where they run around with the CT scanner in the back of the truck and determine that treatment course much quicker. They're trying to put CT scanners in fixed wing planes and having helmet size almost CT scanners that can be used for areas where access to CT scanners are harder, that sort of thing. And so there's a lot of high-end initiatives occurring as well. So watch this space.
Helmet CT, there you go.
Yeah. Well, I don't like calling it helmet. There is another term, but that's what I call it.
I'm sure it's much more technical. Well, thank you for your time tonight. It's been awesome to have you. Thank you for everyone who has watched this. Thank you for all those who are going to listen to this. Next week, I'm going to be doing an interview with a guy from Melbourne. He's a nurse called JP with the Red Cross. And we're going to be delving into his experience nursing in war zones, and some current war zones that currently he has been in. And that's going to be a really good interview. We've also done 15 other live webinars like this, and there's heaps that you can watch. You can watch them all online, listen to them all online. So just type in thenurseBreak.org or nursescollective.org. So yeah, once again, thank you for listening, watching. Thank you, Tanya, for your time tonight. It's very cold where I am right now, so I'm looking forward to putting the heater on and having some mulled wine. So hopefully you enjoy your evening as well. And thank you, everyone, for watching.
Thank you so much for reaching out, Jackson, and giving me the opportunity to speak all things stroke.
You're welcome.